All right, welcome to Endoscopy Now and tonight's virtual education event on predicting progression in BE and the recent advances. With that, I'd like to introduce the moderator for tonight, Dr. Sri Komanduri, who's an internationally recognized expert in advanced endoscopy and Barrett's esophagus. Dr. Komanduri is a professor of medicine and surgery, director of interventional endoscopy, and the medical director for the GI lab at Northwestern University in Chicago. He has published over 100 peer-reviewed manuscripts in gastroenterology and serves as a course director for one of the largest endoscopy courses in the country, Chicago Live. Welcome, Dr. Komanduri. We're excited to have you lead tonight's discussion.
Thanks, Jim. I feel like with that introduction, I should just leave right now. Thank you for that. It was very nice. Welcome, everyone, to a very hot and burning topic, I think, in all of our minds, and it's going to be an exciting evening. We're lucky tonight to have two of really the world's experts in this disease when we talk about Barrett's esophagus, and we're going to really try to encourage participation on your side. And any questions that you have, please type them in real time. We will address them. Given we have two panelists and two speakers, we'll try to take some of the questions in between, and then hopefully have a pretty robust discussion at the end on this topic. So thank you once again for coming, and I'd like to welcome our panelists for tonight. They don't need introduction, but first we'll have Dr. Prasad Iyer, who again is a world expert in Barrett's esophagus. He's a director of esophageal diseases and interests at the Mayo Clinic. And he'll start us off, and then it'll be followed by Dr. David Diehl, who is the director of interventional endoscopy in the Geisinger health system, and he will follow as the second speaker. And again, please encourage any questions that you have, and we look forward to a fantastic evening. I'll hand it over to you, Prasad.
Thank you, Sri and David, and thank you for the kind invitation from Endoscopy Now. So I am just going to try and share my slides. Okay, can you see my slides?
Yep.
Okay, very good. So without much ado, I'm going to get started here. And these are my objectives for tonight, which is to understand the risk of progression in Barrett's esophagus. Second, to understand some of the known predictors of progression in BE. Third, to discuss what would be the potential implications of a Barrett's progression prediction model. And lastly, and perhaps most importantly, to review data on the prediction of progression models in BE, whether they are clinical factor-based or whether they are biomarker-based, and discuss some of the new and exciting technologies that have come forth in the last several years. So this table summarizes in a fairly concise manner the progression risk that is known in patients with Barrett's esophagus. And typically we stratify this by the grade of dysplasia that patients have. So these three estimates are for the three known histologic groups in patients with Barrett's. And I've picked data from systematic reviews and meta-analyses. So patients who have no dysplasia have the lowest risk. And current estimates would put this risk at about 3.3 per 100,000 patient years. Those who have low-grade dysplasia have a more variable risk. And again, I'll allude to this later on in the presentation, because there is a fair amount of inter-observer variation in the diagnosis of low-grade dysplasia, and hence progression estimates vary. But I would say they are in the realm of 3 to 5 times that of no dysplasia. And then, of course, high-grade dysplasia has the highest progression risk, about 66 to 70 per 1,000 patient years. So I think it's important for us to keep these figures in perspective as we go through the next few slides. Now, why is this important? This is critically important because at the moment, if you read Barrett's management guidelines, the dysplasia grade is really the sole determinant of management recommendations. So I've kept the same table, but I've added a new column in terms of management. So those who have no dysplasia, who have a fairly low rate of progression, are recommended to undergo surveillance perhaps every 3 to 5 years. Those who have low-grade dysplasia, our recommendations have evolved from surveillance every 6 to 12 months, depending on which guideline you read, to some suggestion for endoscopic eradication therapy with either radiofrequency ablation or other alternatives. And of course, with high-grade dysplasia, the recommendation, given the substantially increased risk of progression, is endoscopic eradication therapy. Now, the important thing to also remember is that in the community where most of the patients with Barrett's are seen, patients with no dysplasia are the commonest. So I would probably estimate this to be about 80% of all patients in the community would have no dysplasia. Maybe 10 or 15% would have low grade, and then the remaining 5% may have high grade dysplasia. So this is important for us to keep in mind as we think through the recommendations. So what does endoscopic surveillance entail? Its goal is to detect prevalent dysplasia or carcinoma. And the method is to inspect for focal lesions, which should be sampled separately, and then perform 4-quadrant Seattle protocol biopsies every 1 centimeter for those with dysplastic Barrett's. This is really for those with low grade. And then in the non-dysplastic Barrett's, we recommend every 2 centimeters in a 4-quadrant fashion. However, surveillance is not perfect. There are several limitations of surveillance. I think an important limitation is that, at least as they stand currently, surveillance recommendations are not personalized to the individual risk a patient has. They are just based on dysplasia grade. And this is despite us knowing that the risk of progression is very variable even within dysplasia strata. Why might this be? This is, I think, because dysplasia is not the sole risk factor for progression. So this is a table that I've borrowed from a paper we published in CGH about almost 3 years ago now, where we looked at the multiple factors which predict progression. And as you can see, the factors that I've highlighted in black, whether they be demographics such as age or male gender, whether they be lifestyle such as smoking, of course, Barrett's characteristics, length of the Barrett's matters. And then, of course, medications like statins or PPIs may actually cut the risk of progression. Again, this is non-randomized data, of course. So what this leads to is that the recommendation to perform surveillance only on the basis of dysplasia makes this a not very cost-effective process, especially in the non-dysplastics, because there the overall rate of progression is low. And of course, unfortunately, we know that endoscopists are not very compliant with recommendations, and this leads to a phenomenon of missed dysplasia or adenocarcinoma, and this has been well described in the literature, with rates of about 25 to 33%. Now, what might be the implications of predicting progression in terms of personalizing the management of these patients? So of course, if we come up with a prediction tool and we say that your risk of progression is low, then conceivably you could either recommend decreasing the surveillance, the frequency of surveillance, or perhaps stop surveillance totally. On the other hand, if you have a high risk of progression, then perhaps you could be subjected to more intensive surveillance or maybe even proactive ablation. And of course, this is all with the goal of making the management of those with Barrett's more cost effective by decreasing the costs of ineffective or unnecessary surveillance, which unfortunately happens in the vast majority of patients with non-dysplastic Barrett's, and also by targeting the surveillance too and preventing adenocarcinoma in those who are at highest risk of progression. So keeping this in mind, there has been a plethora of Barrett's progression scores. And of course, given the limitation of time that I have, I'm going to highlight a few. So this is called the PIB score, or the Progression in Barrett score, which was put together by the BEST group, which consists of 6 referral medical centers across the United States. They used a total of almost 2,700 patients. and then came up with the score they called the PIB score. And they started with about 11 factors and narrowed them down to a panel of 4 factors, which is male sex, cigarette smoking, Barrett's length, and confirmed low-grade dysplasia. Now, instead of just stopping at a regression model, they took it one step further in the sense that they were able to assign a point score to each one of these 4 components and predict progression risk on the basis of the points. So there were 9 points for male gender, 5 for cigarette smoking, 1 point per centimeter length of the Barrett segment, and 11 points for confirmed low-grade dysplasia. So again, highlighting the importance of low-grade dysplasia as well as male gender. So if you had a low score, which was 0 to 10 points, you had a low risk of progression. If you are intermediate, 11 to 20, risk of progression about 6 times higher. And then if you were high, this is now about almost 20 times higher is your risk of progression. So remember, the overall absolute value is fairly low, but we are talking in terms of a relative risk here. So again, what did they show when they looked at it from a Kaplan-Meier perspective? Again, they could see that the risk of progression was very different in the low, intermediate, and the high-risk groups. And importantly, they presented this value of a parameter called the C statistic, which is a measure of how accurately does the model predict events. And goes from 0 to 1. Higher it is, the better the model. And again, the C statistic was 0.7. So I would probably call this modest, right? We want this ideally to be as close to 1 as possible, but certainly above 0.5. So that was the C statistic of this model. So again, very simple, clinically based. You don't need any fancy biomarkers, but this is what this score can get you. Now, of course, their recommendation was to consider discontinuing surveillance in those who are very low risk, and then continuing surveillance in the intermediate and the high risk group. Now, what are the next steps? It's important, of course, and these were some points that were raised in the paper itself, is that this score was developed in a referral center cohort. So centers like Kansas University, Cleveland Clinic, University of Arizona, etc. And it is conceivable that the progression rates of patients in these centers is higher than that in the community. So what we need is an external validation. And ideally, this should be validated in a population-based cohort. And the first paper that came out about 2 years after the original paper was from the Northern Ireland cohort, which is a population-based cohort, but retrospective. And the area under the curve was about the same. So that I thought was good. Unfortunately, when we applied this model to the Mayo Barrett's esophageal adenocarcinoma prospective registry, the area under the curve dropped to about 0.64. So again, this can happen when you develop a model in one population and try to apply it to another population. And of course, there is the issue of variability in some components. We all know that patients with low-grade dysplasia are oftentimes overcalled by community pathologists, and they are most often downgraded when the pathologist in the academic center looks at them. And even amongst the academic pathologists, there is poor inter-observer variability. And of course, one has to remember that, going back to my original point, that patients with no dysplasia are about 80% of what we see in the community. Once they don't have low-grade dysplasia, then the score is not very helpful. It is, if you take that out, then everybody is sort of on the low-risk end, unless they have very, very long segments. So again, that's a limitation. So this has prompted a number of investigators to look at biomarkers. And biomarkers have been looked at. I don't mean this to be a comprehensive review at all, given the time limitations, but I've tried to summarize in the next couple slides results of some important studies. This is P53. It has several challenges in its use, but really, when you look at retrospective studies, systematic reviews, and meta-analyses, whether they be in case control or cohorts, the odds ratios or the relative risks are impressive. Unfortunately, all retrospective. Again, people have also tried to combine other biomarkers, with P53 like P16, tetraploidy, again retrospective, high relative risks, almost close to 40 here. Abnormal DNA ploidy, P53, an expression of this protein called AOL, again in a retrospective analysis, so this was a validation cohort, again sort of modest odds ratio, but low-grade dysplasia again stands out as something that predicts progression. Other molecular progression panels, FISH, which stands for fluorescence in situ hybridization, which can be performed on esophageal breast cytology. This was a paper from the Netherlands. We at Mayo Clinic have looked at this as well. Again, relatively small number of progressors in a prospective cohort, however, sensitivity of 86%, but a specificity of only 54%. And this model has not been externally validated. An 8-methylated DNA marker panel from the Johns Hopkins group, again, retrospective cohort, fairly decent sized cohort here, somewhat low sensitivity, specificity of about 90%, again, has not been externally validated. So this sets the stage for a technology that I am going to share some data with you today. This is called TissueCypher, and essentially it is a lab-developed test done in a CLIA-certified clinical laboratory, and it essentially studies 9 protein-based biomarkers all together on a slide with multiplexed immunofluorescence, wherein the slide is labeled together for 9 biomarkers, and these are just some beautiful images that have been published in papers looking at these different biomarkers. You can look at, they look at P53, P16, COX2, HER2/neu, K20, and there are a total of 9 of these. And they also look at nuclear morphology, and then using an image analysis platform and using a predetermined algorithm, a risk score is generated, which condenses these 15 features into a risk score, which is then divided into 3 categories, which predict progression, the risk of progression to high-grade dysplasia or adenocarcinoma over 5 years. So how is this done? The report is basically will tell you what is the risk category in terms of the 5-year progression risk, whether it is high, whether it is intermediate, or whether it is low. And again, this is what a report will look like, goes from 0 to 10. It'll give you a numeric score and then also break the score into these 3 categories. Now, I'm just going to quickly walk you through some of the studies that have been done on the TissueCypher, and then take you through a pooled analysis that has also been recently completed. So this was the first paper that was published. This was a retrospective multi-center cohort of about 76 progressors matched to 287 non-progressors. And again, in this case control study, the TissueCypher assay predicted incident progression from non-dysplastic Barrett's or indefinite or low-grade to high-grade dysplasia or cancer independently of clinical variables. So again, this is a Kaplan-Meier curve. The samples were taken from the University of Pennsylvania, from the Academic Medical Center, the University of Pittsburgh, and from Geisinger. And essentially, those who were in the high-risk category, which is the red curve here, had an almost 10-fold increased risk of progression. The second study was an independent validation of the same test. So the important thing to note here is that the parameters were set, the algorithm was set, and only the samples were changed. So that's an important step to take in any biomarker assay development. And as I alluded to before, this was a validated validation study to predict the progression from non-dysplastic, indefinite, or low-grade to high-grade or cancer. And again, they used an independent set, about 60 progressors, about 200 non-progressors. And again, as you can see, the highest risk group, which is the red group, which is the high-risk group, had about a 5-fold higher risk of progression compared to the low-risk group, which is in the black. And now, if you were to look at some of the more conventional parameters we expect for a test, such as sensitivity. Sensitivity was 28%, specificity 86%, and a positive predictive value of about 23%. So again, one could argue that this is somewhat, this could be improved upon, but this was, remember, a validation cohort. Now, the other side of the picture is that if you were low risk on the TissueCypher, the negative predictive value was high at 96%. So I think that is another bit of information that is very helpful and perhaps could justify a change in management of those who are at low risk. The third study using the same assay was performed in a prospective cohort of patients which have been accumulated in the Netherlands called the Rebus cohort. And this was a nested case control study within that cohort of 38 progressors and 38 non-progressors. And interestingly, they also looked at additional spatial, and by spatial, I mean taking biopsies not just from one level, but from multiple levels, and then temporal biopsies, which is taking biopsies from multiple endoscopies as opposed to one endoscopy. And they showed fairly conclusively that if they took more biopsies in the same endoscopy, or if they took biopsies from multiple endoscopies, your prediction ability actually improved. So again, single level analysis, hazard ratio of about 3, spatial analysis, hazard ratio increases to 5.5. And then if you take multiple biopsies from multiple procedures, your hazard ratio goes up to 7. And indeed, in a completely new validation set, the hazard ratio was about 6 in the high-risk group. So again, this is a panel which has now been studied in three cohorts. And the fourth study looked at a prospective cohort of the SURF trial. So the SURF trial was a multi-center European study which randomized patients with confirmed low-grade dysplasia to either surveillance or radiofrequency ablation. And the investigators here took an interesting tack in the sense that they took 155 patients, all of whom had been diagnosed with low-grade dysplasia in the community. And remember, most of these patients are actually downgraded to no dysplasia by academic pathologists. And they tried to see how did this model do in comparison with the 3 expert pathologists. And the model did, I would say, almost as well as any of the 3 pathologists. So again, being in the high-risk group, increase your odds of progression by about 7-fold. And look at the hazard ratio of pathologist 1, pathologist 2, pathologist 3. They are all sort of in that range. So the panel did fairly well compared to any of the 3 pathologists with a sensitivity of 68% and a specificity of 78%. So now I'm going to walk you through the last section in terms of a pooled analysis that we have performed at Mayo Clinic. And these are data from these 4 independent case control studies. And again, we have progressors and non-progressors, and we performed multivariable conditional logistic regression, wherein we are looking to test the association of the assay results with progression, and also compare the C statistic of a model with and without the TissueCypher to see what is its incremental value to clinical variables. So again, this is a busy table. I'm just going to point this out to you that we had close to 475 patients, of whom most, again, I think this is important, most of whom had no dysplasia. And there was a smaller cohort of patients with either low-grade or indefinite dysplasia. Overall rate of positivity in terms of the high-risk TissueCypher score was about 15%, 16%. And as you can see, the rates are significantly higher in those who had confirmed low-grade dysplasia, lower in those who had non-dysplastic Barrett's, and somewhere in between in the indefinite dysplasia. And this is the first model I want you to take a look at. So this is patients of the entire cohort, so 475 patients. This is without the TissueCypher, and we are only using clinical variables. So age, sex, expert diagnosis of indefinite versus no dysplasia, low grade versus no dysplasia, presence or absence of a hiatal hernia, and the segment length in centimeters. And again, the 2 factors which stand out are low-grade dysplasia and segment length. So no surprise. And the C statistic for this model was 0.68. Now, what happens when we add in the TissueCypher? So as you can see, when we add in the TissueCypher, whether it is high versus low, odds ratio of almost 8, or indeterminate or intermediate versus low, odds ratio of about 2, it's these two variables along with the low-grade dysplasia and the Barrett segment variable that remain significant. And the C statistic increases significantly to 0.76. And this likelihood test ratio, which compares the C statistic with and without the TissueCypher score or category, is very significant. Again, a similar comparison with only patients with no dysplasia now and without the TissueCypher. So again, when you look at this, about 400 patients, only the Barrett segment length and age are significant predictors. What happens, and C statistic is 0.62. Now, when you add in the TissueCypher, whether it be high versus low or intermediate versus low, the C statistic increases by about 10% to 0.72. And again, significant difference between the model with versus without the TissueCypher score. So I think the TissueCypher is a panel that has significant advantages. I think it can, well, it's done on not fresh frozen tissue, but on formalin fixed paraffin embedded tissue. It is automated, so there is lack of any subjective interpretation. The methods and the cutoff thresholds for the risk levels are standardized and set. Cutoffs have been validated in multiple independent sample sets. Now, it remains to be seen where is this going to be most helpful. At least one way of looking at this is that perhaps it is more helpful in those who have no dysplasia compared to those who have low grade, where ablation is recommended, though one could argue that in those who are borderline for ablation for low grade dysplasia, it could still play a role in helping us make a decision one way or the other. And of course, I would also like to add, and this is the data that we did not show, the prediction ability remains maintained when we dichotomize the result into high versus low. So 2 categories instead of 3 categories. So in conclusion, progression in Barrett's is dependent on baseline pathology. Progression rates are low in non-dysplastic Barrett's, making current surveillance practice inefficient. Prediction of progression in Barrett's by clinical parameters alone is possible and is certainly feasible. I would argue that the accuracy could be improved. And I think the addition of a biomarker panel can augment the accuracy of this prediction and hopefully change management in those who have low risk by either extending or discontinuing their surveillance, or those who have high risk by putting them maybe into more intensive surveillance or considering ablation in the really high risk ones. Thank you.
Thanks, Prasad. That was fantastic. So one quick question. The data you presented from this recent analysis is pretty compelling. I particularly enjoy the idea of stopping surveillance in some of these patients. So where do you think, with this data adding to what's been done, where do I go as a practitioner? I keep doing continued surveillance on these patients. I understand that you may not be professing that every patient needs to have this, but there seems to be some advantage here to whether or not we're ready at this point to say, hey, I'm going to discontinue based on, even despite what you showed. There seems to be that negative predictive value to me is very attractive.
Yeah, no, I think that's a great point, Sri. And I think it all depends on what the risk assessment of the patient is. And I think the way one could conceivably approach this is maybe before you even talk about stopping surveillance is to maybe even prolong surveillance. So we know from Sachin's paper that a lot of patients are coming back sooner than recommended. So I think this can help us at least push them out to 5 years. Maybe even go to 7 years if they are extremely low at a low risk of progression. And maybe in those who are sort of, approaching an age of 80, 85, and you want to discuss this issue of stopping surveillance, they are maybe not great surgical candidates. This could be one more point which could help us tip the balance, right, in terms of one versus the other. So I think all of those instances would be helpful in my mind. I also think that this could provide us one more reason in people who may have no dysplasia but might be very young, may have a family history, might be on that cusp of indefinite dysplasia. What should we do with those patients? And I think this would be another variable to use to make a decision in those patients as well.
Yeah, what I like about what you've said is it's interesting because that 3 to 5 year recommendation that we sit on now, many people I see, most people are afraid of going to the 5. They stay with the 3.
Yeah.
We're used to that, and I think even that jump is a dramatic, is a change. That would
absolutely.
Be, and you did present the data there that this could be a one-time test. It's not something we need to run every time we do surveillance, right? So in other words, if we know it once, it seems to carry through longitudinally for the same patient.
There is one paper that looked at 5-year prediction and also 10-year prediction. Now that's only one paper, but the results seem to be maintained at 10 years. But certainly for the first 5 years, I think one could quibble with the data, right? When you think of what the NCI wants, you want to go from phase 1 to phase 2 to phase 3 and then phase 4. So you have to go to a prospective cohort. And I think this is at least one of the panels which has gone as close to phase 4 as one can possibly imagine. Well, they might be at phase 3. Yeah.
Great. So maybe David, I'll have you step in here real quick and how are you risk stratifying patients in your practice now, and what does this data maybe say what changes would you make potentially moving forward?
Oh, well, that's a great lead-in to my slide deck.
So maybe we won't answer that. Maybe we can put that on hold and let you say that if you want to wait on that.
Okay.
Prasad, what about you? You've done the data, you've done the research here. With what you found, has this changed the way you clinically risk stratify patients?
I'm not going to say that I have incorporated this in my practice, but most of my practice is in patients who have dysplasia. So I don't see a lot of non-dysplastics. But at the very least, I think if I have short segment Barrett's versus long segment Barrett's, if I have a male or a female, I do factor those things into, do I bring them back at 3 versus 5 years? I think that is something that I have done. And of course, all of this is predicated on the fact that you're confident of the kind of surveillance you are doing. Yeah. You need to be sure that you are doing good surveillance, right? So you got to meet those criteria of 4 quadrant biopsies every 2 centimeters, and you shouldn't be taking 2 bottles in a 10 centimeter segment of Barrett. So if you meet those criteria, then I think all of this holds. So that's something that I'd like to emphasize and stress as well.
Yeah, that's excellent. So I think we have a lot of questions. But what I want to do is let's let David talk, because I think it's a progression of thoughts here that we can then go back to the questions. But that was very exciting data you presented, Prasad. David, I'll hand it over to you.
Okay, thanks. And thanks, Prasad. I really enjoyed that presentation.
Oh, thank you.
So I also, like Prasad, most of my practice is managing dysplastic Barrett's, not doing a lot of screening. But I would like to talk about how we have been using the TissueCypher in clinical practice at Geisinger. This was a paper that we recently published, TissueCypher Barrett's Esophagus Assay Impacts Clinical Decisions in the Management of Patients with Barrett's. So what we did was, over this period of almost 4 years, we looked at our consecutive TissueCypher orders, which was about 86. And we had a pre and post TissueCypher management plan survey that was sent. This is 2 endoscopists, me and my partner, who manage all the Barrett's. And the survey asked about the endoscopic surveillance options, 3 to 6 months, 1 to 3 or 5 years, and treatment options, and it enumerated all the possible treatments. And that information was gathered before and after the TissueCypher came back. In addition, we got patient demographics, description of the Barrett's, and pathology data. So out of these 86, 5 of them, it was ordered for expert diagnosis higher than low grade. So we didn't include those, leaving 77. And we were lacking some of the management decision surveys in 17. So we had 60 patients that we looked at and how it affected us. So the indications in our practice really boil down to 4 buckets. The first one was to support a do not treat strategy for low grade. And an example would be, we have a patient with low grade but significant comorbidity, high risk for treatment. Maybe they're very elderly, perhaps dementia or other things that it would be hard to subject him to EET. The second group was to support a do not treat strategy for other clinical situations. An example of this is someone who had dysplastic Barrett's. We ablated them, and after multiple ablation sessions, there's a little bit of Barrett's left, but it's non-dysplastic. So we would order a TissueCypher to see, okay, do we have to take this person all the way to where there's not any Barrett's? The third one was to help define treatment or surveillance plan for these patients with indefinite dysplasia. And the fourth group, where there was a clinical or endoscopic concern. For example, there was worrisome features. So there's a patient with Barrett's with a polypoid lesion present, or sometimes the mucosa is very abnormal, but not frankly nodular, and we would check a TissueCypher. We were looking at in patients who had a history of intramucosal carcinoma, which we cured with an EMR. I was interested in checking the rest of the Barrett's to see what the score would be. And then there were some cases where there was discordant path results from an outside biopsy compared to a repeat biopsy at Geisinger. So those are the 4 groups that the test that we ordered could be fit into. And what we found was it actually affected decision-making in 55% of cases. It upstaged management, meaning it led to either more frequent surveillance or endoscopic ablative therapy, and 22 in a downstage and 33. In a couple of patients, after they came back with their TissueCypher, some other medical issue took precedence, such as malignancy of another kind, and it didn't change management of 42%. When we look at those 4 groups to see where the effect was, it was interesting that for risk stratification in the indefinites, it did lead to change either upstage or downstage in quite a few. This indefinite group is, it's hard to know what to do with those patients. It's somewhat worrisome. I mean, I used to think that, this is probably closer to non-dysplastic than even low grade, but in light of some of these findings, I'm not sure what it really means. The one group that it was not very useful was these patients with a clinical or endoscopic concern, in that it really didn't change what we did. For example, if we had a patient with that intramucosal carcinoma that we cured with an EMR, we're still going to ablate them, even if the TissueCypher came back with a high number.
Yeah.
Regarding the histology and how it affected, I'll point out for the indefinite group, for example, upstaged the treatment in 7 and a downstage in 8. And by downstage, I mean we could do less frequent surveillance, but somewhat surprisingly, some of these patients with indefinite came back with a high TissueCypher score, and we were unwilling to just continue to observe them, and we pursued EET on those. And you can see the results for either non-dysplastic histology and low grade. So in conclusion, from this study, the TissueCypher impacted 55% of management decisions, with upstaging in 22 or downstaging in 33%. And so the TissueCypher can provide novel insights into the biology of Barrett's beyond the histologic appearance. I'd like to give you just a few cases illustrating how we use this test. The first one, this is a case that I would classify as a downstaged case. This was a 73-year-old man with a 4-year history of long segment Barrett's, C9, M11, multi-level surveillance biopsies, always had non-dysplastic BE, and this is multiple biopsies. Then 1 year, he had one surveillance EGD, and a single level was read out as showing low grade, but everywhere else it was non-dysplastic. So on this patient, we sent a TissueCypher, had a low score, 4.1, and this led us to pursue continued surveillance instead of doing, it would have taken multiple EGDs for EET on this patient. And I followed this man for 3 years since that, and he continues to have non-dysplastic BE without histologic progression. So in this case, in my practice and management of this particular individual, it was useful in that it seemed to indicate that his risk was low, and it confirmed that, and we just followed him. There's another interesting case of a downstaging. This was a 72-year-old man. He had a C16, M16 Barrett's, a very tortuous esophagus. You can see that picture, very dilated, tortuous. Biopsies showed non-dysplastic BE with one level with indefinite. So he was seen at another center, and an interventional endoscopist started RFA, which was very difficult in this dilated and tortuous esophagus. And he actually gave up due to lack of efficacy, and he referred this patient to one of our thoracic surgeons for esophagectomy. And the surgeon sent him to me for another evaluation. So I did a very careful endoscopy, of course, using NBI and acetic acid chromoendoscopy, and didn't see any specific areas that were worrisome. And of course, it's a very difficult evaluating an esophagus like this. So I did Seattle protocol biopsies and did TissueCypher on those samples at several levels, and the score was low at 4.8. And in this patient, it allowed me to feel more comfortable supporting a surveillance strategy. And ablating this patient would have been very hard, possibly impossible. And he might have even ended up having esophagectomy, but with a low TissueCypher score, I followed him, and 2 years after that, in fact, I saw him last week, unchanged, and the biopsies continued or without dysplasia. And here's one case of a situation which led to upstaging. This was a 61-year-old man with a 3-year history of Barrett's, but fairly short, a C0, M2. He had, on this surveillance endoscopy, as you can see, it was a very flat BE. There was no nodularity. There was some erosions under even acetic acid chromoscopy. There's really nothing that caught the eye. But the biopsy, I did biopsies, of course, and they were read out as indefinite. Somewhat surprisingly, his TissueCypher score was high at 7.9. And on the basis of that number, I decided to pursue endoscopic ablation with RFA. So in this particular patient, the TissueCypher allowed more exact characterization of the indefinite dysplasia, which did lead to endoscopic eradication therapy. So presumably, this treatment prevented a progression to worse histology. Those are all my slides. So that's basically how I have been using this test in my clinical practice of management of these. I get referrals like Prasad does for dysplastic Barrett's and high-risk cases, or confusing histology. I mean, and I'm sure Prasad has seen this too, an outside biopsy showing cancer, and I'm there and I can't find anything, and at most low grade on a biopsy. So it's useful in cases like that.
Yeah, that's great. Thanks, David. That was very helpful. I think one thing that a question that came up here is, what do you both think about patients who have been followed repetitively for years in surveillance program, always non-dysplastic? Can we do something to stop, extend? Do these patients actually have a lower risk of progression because of the number of endoscopies that have been negative?
Yeah, I think, there have been, I think, a few papers which have shown that if you have repetitively negative biopsies for dysplasia, then your risk of progression is low. We try to replicate that in our own cohort, in our own sort of registry, which is a prospective registry, and we did not see that. So I don't know if I think the jury might still be out, but certainly, you could easily make a case again for going from 3 to 5 years for these people, in my mind. And again, with the caveat that the surveillance is being done in the right way with a good quality surveillance, adequate biopsies, then I think it's certainly reasonable in my mind, if it's done the right way.
Another question, not to open Pandora's box tonight, but what about some of the other new innovation in this area? What do you both feel about when the data you presented was very strong, but what about things like Watts and that technology, specifically around risk? I don't know, maybe David, what do you start with you?
You know what? I'll have to defer to Prasad. I haven't been using Watts, so I can't comment on it.
Prasad, what do you think?
Yeah, I have to confess, we don't use it clinically, but when you look at the data, I think there's a fundamental difference between Watts and TissueCypher or any of these prediction biomarkers, because Watts is really looking for prevalent dysplasia, right? Dysplasia that is present at that time. And I think it is a great concept and a great technology in the sense that it increases sampling. If it's used as an adjunct to biopsies, I think you sample a bigger surface area of the Barrett's mucosa, and the artificial intelligence conceivably increases the yield of dysplasia, and that's what studies have shown. The only questions in my mind are, what do you do when Watts alone says you have dysplasia and your biopsies don't? What does that mean? I think in my mind, and I might be in the minority in that, or at least on one side of the argument, I don't know if we really know that.
Yeah.
And is that equivalent to histologic dysplasia, low grade, high grade, or cancer? Can the data that is reported on Watts, most of the data has come from their own pathologists. Can it be reproduced outside CDX? I think that is an important thing in my mind as well. So I have some questions in that regard. But I think it's a great concept, and I completely agree with the need to sample more mucosa and to look at the cells that we get in a careful manner.
Yeah, for me, I agree. I think it's two different things. I think when we talk about progression and risk stratification, the studies that have been done here with TissueCypher are much more in that track. When I think of Watts, I think of, can this replace Seattle protocol, right? Can this, it's interesting because we continue to have all of these lectures and discussions when every step of our pathway is weak, right? Everything. Yeah. How we do endoscopy, how we interpret, how we sample, and then so it's hard to even say what are we telling the patient in the end in terms of diagnosis. So I think there is a lot of interest, and I think it's we've done some work with Watts. We're actually trying to even look at it post ablation because again, what we do now with random biopsies is sort of futile, and can you get a field defect? And again, just picking up whether you have intestinal metaplasia that's persistent, it would be helpful. But I think for Seattle protocol, I think even the best of us, and luckily, I think you guys are lucky. I probably do a little more surveillance than you do, but that pain is gone from you a little bit of spending, but everyone in the audience knows that pain. And no matter how much we can preach that, it's very challenging to spend that much time to sample this area. So I think,
absolutely.
To answer the question, I think those were very helpful. I think maybe two different pathways of innovation, one to address a problem of sampling and one to address progression. I think that's exciting for us, I think, in the field to have some of this innovation.
I think there was one paper which looked at prevalent dysplasia and TissueCypher as well. Relatively small study, but again, I think they were able to show that even though the biopsies were negative for dysplasia and these patients progressed within a year, which meant that the dysplasia was missed, the score was high, which again should alert you that maybe you didn't sample as well, or maybe this is one of those people you want to bring back sooner, look more carefully, et cetera, et cetera.
Yeah, go ahead, David.
Another point, and Prasad, the last paper he was talking about, he was comparing expert pathologists. I mean, AMC, I mean, there's very few places have Barrett's pathologist as good as that.
Mm-hmm.
And the tests perform similar to an absolute world expert pathologist. So it brings that level of expertise to a more general setting. You know,
Yeah.
a hospital has a general pathologist who does, you know, maybe doesn't specialize in Barrett's.
Sure.
So it can bring that expertise to bear.
Absolutely. Absolutely.
One more question. Prasad, I think you have an interest in this area, but now that we are looking at non-invasive screening modalities, you know, what about something like this as an adjunct to that? You know, when we, you know, to not only screen but potentially use the acquisition of the cells to risk stratify as well.
Mm-hmm. Yeah, no, I think this goes hand in hand with the studies where I think there was the validation study in the US and then also the study from the Rebus cohort basically showed that if you use samples at multiple levels, you increase the predictive value, you increase your sensitivity without compromising your specificity. So I think it goes to the fact that if you improve the sampling or maybe use a more representative sample of the whole segment as opposed to one level of biopsies, then conceivably your prediction will be better. And I think a sponge or a brush, in my mind, is an ideal sample because it samples everything. And there is very minimal inter-endoscopist variation because a sponge comes out the same regardless of, you know, who's pulling it, and should sample much better. So I don't know if there is data to that extent, but certainly I would think that the signal is there from these two studies that the more number of levels you examine, the better your sensitivity becomes.
It seems like it would be worth doing a study looking at TissueCypher, if it's possible to do it on exfoliative pathology.
Right. And we might need cells as opposed to DNA, because at least the markers that they are using at the moment are done on, you know, they're done with immunofluorescence. So I think some modification of the assay may be necessary, but certainly that seems reasonable to me. Yeah.
That's great. I think, you know, another way also is now that we're sort of inundated, when we're sitting with a patient, there's so many potential risk factors, that some of which are just weak clinical risk factors, and a tool like this, you know, is there some potential? Ultimately, we all want to make this objective, right? We want a blood test, we want a number, we want a MELD score, we want something. We want, you know, can we take all this where we may be in the next few years and create that for Barrett's? Do you foresee that we're going to see a patient, give them, you know, not just a diagnosis with some questionable pathologic variability, but now here's your sort of
a score, a Barrett score. Yeah. No, I think that's, you know, one way of looking at this might be to do clinical. So I showed you the model with and without the clinical variables, right?
Yeah.
So I think that's a platform for doing just that, because you have age, you have sex, you have length of Barrett's, and you have dysplasia grade, and then you have your TissueCypher score. And I think that could be a very powerful way of showing, this is your Barrett score, so to speak. And that determines what you should be doing.
Yeah. No, I agree. And I think, we spend so much of our time answering questions about what's my risk for cancer, doc? What's my risk?
Yeah. Yeah.
We spend, and to what you pointed out today, we spend less time saying, what isn't my risk, right? So, people are given this, and frankly, we've had how many discussions and papers about, what the value of an irregular Z line, and we can have another 10 webinars on this, right? Of everyone's different opinion. But I wonder if it's time now that we take some of these areas and look into, are there some tools like this that can help us get out of unnecessary utilization of resources?
Absolutely. I think if we were, the challenge, I think, is that we live, unfortunately, in the United States, which is somewhat litigious, and therefore our risk tolerance is exceptionally low.
Yeah.
But it's very, I think it's very logical to think that if you have a low score, let's say a low Barrett score, then your surveillance interval should be different, or your management should be different than someone with a high score.
Yeah. No, I agree. And I think that's kind of what we're headed. And I think the data that you showed, that's sort of fresh. I think maybe that's our next step here, is how to assimilate all this. And
yeah.
Because I know from the participant standpoint, even we all want some guidance on clinical practice, right? What do we do tomorrow with that patient? And I don't think it's that easy yet still, but I think this is really favorable in that we finally have progress.
The other thing to also remember is that these are still sort of case control studies. So all of their estimates are, even though they talk about a prevalence adjusted estimate, it is just that. It is not something that is coming from a true cohort study where you're following patients forward. That might be very difficult to get in a field like Barrett's, just because the overall risk of progression is so low that we may have to be satisfied with a slightly lower level of evidence.
Yeah, I agree. And I think we've all talked about this before, and the ability to do longitudinal prospective studies and RCTs in progression of non-displays, at least at this point, is impossible unless screening somehow tenfold increases our volume. It's almost impossible. But and so I think this is our next best step. Well, that's fantastic, guys. As we wrap up here, we have a minute. Any final thoughts from either of you in terms of advice to the participants on all new innovation in this area as they move forward?
I mean, one thought I have is artificial intelligence is obviously moving fast in all of medicine, and in pathology, it's really quite a bit. I think radiology is probably number one, and pathology is probably number two. And I think we'll look back at how quaint it was for someone to peer through a microscope at cells and sort of try to figure out what they're saying. I think we'll be going to an AI type platform, and this multiplex immunohistochemistry may well be part of that, to stratify histology on something other than just an opinion of a pathologist.
Right.
Yeah, I think that was a great way to put it. Thanks, David. All right, with that said, I think this was a fantastic session. I want to thank everyone and the panelists for joining us tonight. I'll hand it back to you, Jim, to wrap things up.
Great, wonderful. Well, on behalf of Endoscopy Now and tonight's sponsor, Cernostics, we want to thank Drs. Komanduri, Iyer, and Diehl for participating in tonight's panel discussion on predicting progression in BE, recent advances, and some of the challenges that physicians face. With that, thank you for joining us, and have a wonderful evening.
Thank you, guys.
Thank you. Thank you so much.
Thanks. Good night.